Hi, I'm Doug Dormer. This is the Abatement Information Masterclass, establishing the criterion standard for opioid settlement funding and avoiding the tobacco failure. This is Lesson 4, Integrating the Community, bridging community service providers and traditional healthcare providers to create a true learning health system. We think of this as the engine room in this process, the reality check. We note that the current partners are data siloed and certainly often data silenced. The hospital paradox. Hospitals have MDs and PhDs and often EHR systems that capture the data, but they are facing systemic capacity collapse. With the pressures we see and hear about in the news every day, we understand that the margins, that every worker is stretched, that their ability to take on new projects is terribly under pressure. So a $50,000 abatement contract is a rounding error to them. Yet it carries a research and reporting mandate. What a burden. There's also a justice gap. Police and courts, often recipients of this money, are the first responders to the crisis. They're the ones that give out Narcan, perhaps. But they are digitally dark. They don't have an EHR. They have limited clinical tracking and no staff trained in remediation evaluation. And then we have the social determinants of health, the SDOH children's table. Housing, nutrition, transport providers have been doing the heavy lifting of recovery for decades with zero clinical recognition. It's time for them to move to the grown-up table. The settlement finally provides that seat, but the need for evidence capture and data analysis is still present in order to stay there. And finally, we have to comment on the shadow providers that don't get enough attention. Faith-based and peer support organizations. These are really the hidden assets. They have the highest trust in the community, but the lowest data maturity. They are the negative space where recovery actually happens, yet they are currently invisible to the healthcare system and to the auditors. We need a solution that bridges that. I want to comment on something we'll call integration friction, the referral black hole. So imagine a scenario. A judge refers someone to a community health services provider, who refers them to a housing provider, who refers them to a job training program. First, no one knows for sure if the person actually showed up at each of those stages. Second, there's a fiduciary risk. If you pay all 4 of these services but can't establish continuity of care, it treats like 4 discrete services to separate individuals, the auditor will call it fragmented spending, and you'll have a hard time justifying it. You certainly won't gain information about the meaning of that intervention. So the solution is a closed-loop evidence system. You need to see the warm handoff in the data and then be able to track it to show a continuity of care to prove that it's truly abatement, not just an activity. So we have what we've referred to as the golden thread of abatement, trying to move from, at best, warm handoffs to true clinical continuity, referring to the black hole. Currently, too often, a warm handoff is just a phone call or a fax. It has no data persistence. If the patient drops out, the evidence chain is broken. That means we have a need for a master patient index. You can't prove sustained recovery if you can't uniquely identify the human being at every touch point. So we need a master patient index that recognizes the client in housing is the same patient in ER, for example, and is the same defendant in drug court, as an example. And you don't need to build this as a new silo. You need it to plug into the existing health information exchange infrastructure. You need a way to allow the data to follow the patient or the client across the ecosystem. Finally, you need an infrastructure in order to eliminate double counting. Auditors and certainly the fund administrators hate paying for the same successful outcome, treating it as 3 separate events because 3 different agencies claim the same person but don't identify that person across the ecosystem. So let's talk about formalizing the non-traditional provider to achieve true abatement. For decades, healthcare has lived in the clinic, and community services have lived in the community. The $57 billion settlement creates the opportunity to erase that line, that barrier. We aren't just referring to housing or food programs. We are integrating them into the clinical evidence chain to document how the services are delivered, how long they're delivered, and what outcomes might be associated with those interventions. We're talking about a clinical grade expectation when a non-traditional provider, a peer support group, a faith-based group, housing perhaps, could plug into the criterion standard, then they are elevated. They move from informal, undocumented support to credentialed abatement partners. And we use the Health Information Exchange as the bridge. By collaborating with HIEs, we allow the non-traditional providers to contribute to the clinical context and the clinical staff worker to better see the social reality in which the client lives and operates. So what's the takeaway? Abatement isn't just a clinical event. It's a community-wide transformation. If your non-traditional partners aren't integrated into the healthcare ecosystem, then your path to true abatement is out of reach. Once again, here's the link to our survey. If you haven't taken it, we hope you will. Thanks for watching this video. Please return for Masterclass Lesson 5, Consumer Empowerment, Achieving Financial Sustainability through Health Identity Trust.